Welcome all to this webinar on teaching a registrar how to engage and manage patients who are overweight and obese. And I think a really important topic, which I'm thrilled to be able to facilitate tonight with our presenter, Alison Lancy. Before I start, I will just do an acknowledgement of country, if that's okay. So we here at GPSA would like to acknowledge the traditional owners of the land in which this meeting is taking place and pay our respects to their elders past and present and their families and those emerging. And we're both joining you tonight from the lands of the Awabakal people here just south of the Hunter River in Newcastle. It is a great pleasure to introduce our presenter tonight, Alison Lancy. Alison's bio is pretty impressive, lots and lots of letters after your name, Al, but I guess predominantly you're a GP here in Newcastle, so FRCGP, and have a B Health Sci in Nutrition and Dietetics, which is where your interest in this topic lies. So since achieving her GP fellowship in 2016, Alison has been firmly committed to striving for excellence in the GP Registrar education program here in the Hunter, Manning and Central Coast region as a medical educator, and she's now Deputy Regional Head of Education. Special interest in preventative health and lifestyle medicine due to her past life as a dietitian and personal trainer, and improving the lives of GPs when managing the health of disabled patients. But I guess most importantly, Al's a very good friend and a very dear colleague of mine, and I have it's a great delight to invite her to talk to help us as supervisors support our registrars to manage patients with this really important condition. Thanks very much, Al.
Thank you, Simon. That was a really nice intro. So yes, I had a previous life as a dietitian many years ago. Funnily enough, though, when I worked as a dietitian, I worked mainly with cystic fibrosis and as a pediatric dietitian, where I was mainly trying to put weight on kids rather than working with obesity. But certainly, from the basis of my interest in particularly lifestyle medicine, as I've gone forward into working as a GP. So I hope that you enjoy the content that I put together for tonight, and hopefully will answer most of the questions that some of you sent through. So thank you very much for sending through questions before the session. There was a couple of things that I wasn't planning to talk about that I will definitely mention to answer some of those questions. So we're going to talk about particularly initiating and communicating specific advice related to diet and exercise for weight loss, and also just general health promotion. We're going to talk about the various weight loss specific medications that are available and how they're used, so how to initiate, how to monitor them, because I know that that's often a really difficult topic for a lot of GPs, and certainly the registrars that I've sat in with in the past have really struggled to know how that works or are reluctant to prescribe them. So we're definitely going to talk about that. And we're also going to talk about when to refer for surgical weight loss intervention. So this is... I just wanted to be specific about what I don't plan to cover. So I'm not going to cover the causes of obesity. Basically, in a nutshell, there's lots of genes that contribute to obesity, and particularly a couple of hormones, but there's certainly no magic bullet specific cause. And there are a couple of very specific medical causes, particularly in like early onset of severe obesity in kids. You know, you would go looking for a medical cause, but in most cases, things like thyroid, conditions and things like endocrine type things tend to be uncommon causes of obesity, and a lot of the time it's somewhere like 40 to 80% of people will have some kind of genetic link with their obesity, but we can't pinpoint the specific genes. There's lots of them. I'm not going to talk about specific types of obesity surgery. And there's a great Australian Journal of General Practice article from a couple of years ago that goes through that. It's excellent, so I recommend that. And I'm also not going to talk about weight management in children, because there's this fantastic Weight for Kids modules that you can do for free that are New South Wales government online learning that I would recommend that you have a look at if you can. And the other thing I'm not going to talk about is specific local resources or referral pathways that are specific to you. I know someone in the questions asked about, something particularly local, but it's just so different. And I will mention that as we go through, but it's so different depending on which area of which state that you're in. So to start with, why should we care about our patients that are overweight or obese? So in terms of the facts in Australia, so we're at the 8th highest country in terms of proportion of overweight or obese adults greater than age 15 years. And about 2 out of 3 adults were overweight or obese, and that was data from 2017. And I have to wonder, after COVID lockdowns and us being confined to our homes for the last 12 months, whether that's might be pushing a little bit higher than that. And about greater than 60% of men and women will have a waist circumference, indicating a high risk of metabolic complications. And then 38% of adults in the lowest socioeconomic areas were obese versus 24% in the highest socioeconomic areas. And certainly when I give this talk to our registrars in New South Wales, I have this great chart which actually has the different suburbs and towns in New South Wales. And I can say, specific towns generally, unfortunately, the rural towns, the remote towns, the towns that don't have as many resources as a city, they tend to have the higher rates of overweight and obesity. And, that's something that is really tricky, particularly if you're a GP or a supervisor in one of those towns where you don't have a lot of resources. But I think the big thing is that the total direct cost of overweight or obesity in Australia is $21 billion a year, which is just phenomenal. And when you factor in costs like to the health system in terms of needing to purchase bariatric equipment, which costs a huge sum of money, as well as the costs of chronic disease and cancer and everything else that goes with it, it's only going to get higher, that amount of money that it costs each year. So in terms of chronic conditions, this is stuff that you will know, but this table basically shows that particularly arthritis, the higher your weight, then the more likely you are to suffer from arthritis, from diabetes, from heart, stroke, and vascular disease, and hypertension. So it's more likely to occur the higher your weight. There's a couple of conditions that don't change a lot, particularly things like mental health, osteoporosis. Asthma does get worse, particularly if you're on the more obese side, but certainly arthritis, diabetes, heart, stroke, vascular disease, and hypertension are the big ones, and which, you already all see that day-to-day practice. So I wanted to include this slide. So this is the things that I've noticed sitting in observing registrars when they are dealing with lifestyle medicine, when they're talking about weight loss with their patients. So these are the things that I've noticed, and feel free to pop in the chat things that you've noticed that your registrars have done too. But the big thing I've really noticed is that they talk too much at the patient. So there tends to be a lot of, I know that I've noticed that your weight's really high. Have you considered losing weight? And just like talking at them rather than asking permission to begin with. Is it right if we talk about weight? Is that something that you're concerned about? And certainly that should be one of that asking permission to talk about it is certainly one of the things that we do encourage. The other thing is that they launch into a spiel talking about very basic lifestyle interventions. So this might be a patient that struggled with their weight for the last 20 years, and the registrar will immediately launch into, have you considered having more fruit and vegetables? And it's really important that you exercise more and that you drink water. And that's stuff that we can get off the internet. And the patient knows that. But certainly that's what I've seen is long spiels talking about really basic stuff rather than assessing where the patient is currently at. And this, not assessing complications of obesity, so not thinking about, their other health, their kidney, their hypertension, if they've got diabetes, not just going, oh, you're overweight, but actually going, okay, are there other complications that are associated with your weight? How much do I need to push this? How much do I need to intervene? And assessing, and later we'll talk about that, the type where you might kind of enter in with your intervention. And certainly there's a big reluctance to prescribe weight loss medications. And look, that I get that, because a lot of that is about just not having that familiarity with it. There's certainly a fear, I think, particularly with Duromine, because it does have a street value, but there is a bit of a fear about prescribing it, thinking that people are abusing it, rather than kind of assessing where they're at and why they're using it and how they're using it. And certainly I haven't seen a registrar prescribe anything else other than a repeat script of Duromine, but certainly this reluctance to consider weight loss medications in any patient, certainly another thing that I see. And this making the patient feel guilty. And look, to be honest, I think we're probably all guilty of this. And it's, I give this one example. One of another GP that I met said that when COVID was happening, they put up a thing on their practice page saying that patients that were overweight or obese or above a healthy weight, had a higher risk of complications of COVID. And even something simple like that, yes, it's factual. A couple of patients reported back to the practice that it actually made them feel worse because they're at high risk of complications of everything. And it was just kind of making them feel guilty again for something that in a lot of cases it's out of their control. So I think guilt tends to play a big part when I've seen registrars, and this big no plan for follow-up. And we're going to definitely talk a lot about that. So this is what I've noticed, and I hope, unfortunately I can't see the chat, but I hope that you guys are sharing some of the things that you also seen.
A couple of things, Al. Interestingly, one thing is not raising the issue at all. And I guess that's possibly the commonest observation, that it's just, and I use this expression respectfully, but the elephant in the room, that, it's there in front of you, but it's just maybe too hard to address.
Yeah, and I certainly see registrars that don't take the opportunity, like you kind of go, oh, great, you're just here for a script for your hypertensive medication. Great, oh, cool, now I can move on to the next patient. Like that, rather than going, oh, okay, I can actually spend a bit of time with this patient with, an early term registrar. I've got a 20-minute appointment. I could actually do some of this stuff. And they just don't do it. So this is the first poll. It's just a bit of fun to get a little bit of engagement, but I'm interested in your experience prescribing weight loss medications. So if you can fill in the poll for me and hit submit, that would be great. 5% of our participants tonight have never prescribed a weight loss medication. About 15% have continued, but about 80% have initiated a new weight loss medication. So that's actually awesome. So I'm very excited to hear that. And then my second question was, have you ever attended a local park run? And so 38% of you said, what's that? Oh, you're breaking my heart. We're going to talk about that. And 28% of you said there isn't one in my town, which also breaks my heart a little bit. 33% said that you've been a few times, and looks like one person out there has their 100 parkrun shirt. So I really want you to own up to whoever's done that, because that's awesome. That nobody's got their 250 parkrun shirt. So we will talk about parkrun. I think from my experience with parkrun, so basically it is a 5K course that is set up usually by a group of volunteers who decide to set one up in their town or in their suburb. And it's a 5K course that's set out, and every Saturday morning at 8 a.m, a whole bunch of random people will turn up and will do the 5Ks at their own pace, whether they sprint it and they're back in 17 minutes or they take an hour and 20 minutes to get back. It doesn't matter how long it takes you. And it's a lovely community atmosphere, and the number of people that I've met, because I have interviewed lots of different people over the years that have gone to parkrun, but the number of people that I've met that have totally turned their life around in terms of going from zero exercise to now having their 100, 250 parkrun shirt, losing huge amounts of weight, recovering from cancer, knee replacement, hip replacement, all sorts of things. And the community spirit that happens with them is amazing. So I cannot press on you enough to go and find your local parkrun if you have one, or if there's not one in your town, to encourage you to think about setting one up. I'll put that out there. All right, so let's move on. So let's talk about communication and assessment. So the big thing that I really want to press upon you tonight is the use of non-stigmatizing language is really, really important. So, and I have already talked about weight and obesity, but tonight. But generally, when you're talking with patients, we say, if someone's underweight, they are below a healthy weight. If they're in their normal weight, then you're a healthy weight range for your height. If someone's overweight, then you can say, look, you're above a healthy weight. Is this something that you'd like to talk about? Or if they're in the obese category, you are well above a healthy weight range for your height. Is this something that you'd like to talk about? Is this something, that I can offer to help you? So use of that non-stigmatizing language. And I've tried to pick photos through this presentation that show people that are above a healthy weight that look happy and are exercising. And because you see a lot of things where it's, a person that's above a healthy weight looking sad with a belly and a tape measure. And that's not the sort of image that we want to put out there in the community. And actually, the training plan for this, with thanks to Simon, we put together, which will be available to access after the webinar. I actually asked them to change the picture on it to make it, again, this kind of non-stigmatizing language and imagery, because I think it's really important when you're chatting with patients. In terms of assessment at baseline, this is the sorts of thing that I would recommend and that you encourage your registrars to do, regularly, and particularly for script appointments, because this is just something it's so easy to do a heart rate, a blood pressure, to do a waist circumference, and certainly from sort of studies, only about 5% of patients have ever had a waist circumference done. So it might even be less than that. And then do a height, a weight, a BMI. Now, I've got baseline ECG there, and certainly that's part of this assessment of potential complications of obesity, thinking about family history. And if you're thinking that you might start a weight loss medication in a patient, particularly Duromine, then it might be worthwhile to do a baseline ECG, particularly if you can do one in your practice, just in case more than anything. And this asks about potential complications. So they have problems with their joints, is there family history, is there sleep apnea, their mental health concerns that potentially are going to be an issue when you're thinking about it for these patients. A focused history. Now, I haven't written it here, but also consider things like your risk assessment tools. So, your cardiovascular disease risk calculator, your OSD risk, those sorts of things, are good to get into the habit of doing when you're thinking about these. And Simon has impressed upon me over the years being rational referrers for pathology, rational prescribers, and certainly, thinking about baseline bloods. A lot of patients will often want to find a cause for their obesity. It's my thyroid or something is going on, they're endocrine or hormonal. And I think, if there's a genuine history there that suggests doing a thyroid or checking their iron or something along those lines, then you should do that. But or their cholesterol, or it's about being sensible. So waist circumference, you're looking anywhere above 94 centimeters and for men and 80 centimeters for women infers an increased risk of metabolic complications if we're a waist circumference. And then when you start getting above 102 and 88 centimeters for men and women, you get this substantially increased risk of metabolic complications with your waist circumference. It's that central adiposity, which puts them at a higher risk of metabolic disease, fatty liver, all of those sorts of things. So that's why waist circumference is so important to do, as well as a height and a weight and a BMI. Because it's that measure of central adiposity. And particularly, you might not see any change on the scales for a patient, but their waist circumference might go down. And that's a great motivator. So it's really good to be doing that at baseline. Now, I put BMI there and just looking at in terms of risk of obesity-related comorbidities. Obviously, above 25 is that where you start developing that increased risk. More than 30, particularly if you've got a big waist circumference as well, that central fat deposition, you get more increase. And then high, very high, extremely high, depending on whether BMI starts going up over 30 and over 40. I prefer using these kind of risk of obesity related comorbidities rather than saying someone's overweight, obese, super obese, or even type 1, type 2, type 3, type obesity. I think it's much I think it's much nicer to patients where you talk about their risk of, future illness and future disease. Now, and BMI is not the be-all, end-all, and obviously most of you will know that some Pacific Islander nations, you can people from those backgrounds, you can tolerate a slightly higher BMI, and then conversely for patients that are Aboriginal and Torres Strait Island or Aboriginal background, or Asian backgrounds, we sort of would prefer a BMI on the lower side slightly. But it really depends. And I think it's best to combine that with a waist circumference.
Just very quickly, Al, because I think that's a really important point, and I'm sitting here thinking I didn't do any waist circumferences today on a cohort of very overweight patients. How can we encourage our registrars to do it? And just practically, where is it? As in, which bit of the big belly that you're...
basically just pick, I usually aim to just go where the belly button is, so around there. But you sort of, you probably want to look for like the largest area, I guess, in the middle, but I think it's easy if you just pick belly button, and just because then you know that that's always going to be consistent for that patient. Particularly if they start to lose weight. And there's some really good like tape measures out there that have the orange and the red on there, so that you don't have to remember the numbers. It's already kind of on the tape measure for you. So that can be quite helpful as well. It's just getting into the habit, isn't it? More than anything.
Absolutely agree. I think once you sort of launch it and start doing it on a few people, it becomes routine.
Yeah. Okay, so in terms of the patient, so I'm not talking about causes, but basically the body aggressively defends any attempt to reduce body weight, and it does that by adjusting hormones, by increasing their appetite, by reducing the amount of energy that the body burns, by reducing your basal metabolic rate. It just does everything that it can to stop you from losing weight. So I think that's really important to acknowledge for yourself as well as with the patient, that it is going to be hard. And it's important to treat it as a chronic disease and support the patient regularly, particularly if they're decided that they're committed. But, the kind of victim blaming is really common in society. They should just eat less. Well, yeah, but like I said, the body really aggressively defends that attempt to lose weight. So it might not be as simple as just eating less or trying to exercise a bit more. And it's really easy to kind of, as soon as you stop doing what you're doing, to wait to go back on. So I think it's really important to talk about that with the patient. I'm not going to dwell on this. I'm sure you've all seen this NHMRC framework for lifestyle advice about asking the patients, so engaging them, assessing them, advising. And again, they talk about non-judgmental language and discussing options for management, assisting them, and then arranging follow-up. So I'm not going to dwell on that, but I think that is still a very good framework. So other info that you might need to know from the patient. So why not does the patient want to improve their diet or lose weight? So what is the motivator and the goal that the patient has? Have they just had a new bub or their kids are more active and they're getting puff chasing them? Like, what's that really positive goal or that really positive reason that the patient wants to lose weight or to improve their health? Basically, your long-term goal for patients, so 10% reduction of weight is, I guess, for people that are well above a healthy weight range. That's kind of what you're aiming for. But in reality, the long-term goal is to maintain a 5% weight loss, and that's it. If they can do that, then that is very, very successful. And that's just based on what we know about how difficult it is to lose weight. And I think it's really important to find out what their baseline knowledge is. Like, what have they tried in the past? Like, what do they want to do? Like, and how adherent are they likely to be? And we're going to go through, like, basically the step kind of management. And as you'll see, each step requires them to be more adherent and more committed. And I think it's really important to find out early on what they like, how adherent and committed they are and how they're likely to be in the long term, because everything is long term. It's not no short term things. And so what tools do they have and what do they need? Like, do they have a smartphone? Have they got a set of scales at home? Like, have they got, like, financially, like, are they able to hire stuff or are there free kind of exercise programs around? Like, what is around? And the other thing that I always talk to the registrars about is this kind of idea of using positive language when you're doing this assessment. So, can you tell me the reasons why you're keen to lose weight? Well, yeah, I really want to be able to chase my kids, and I don't want to end up like my dad who had a heart attack age 50, and I'd really like to have more energy. And by asking the question in a positive light like that, you've heard me say a lot of positive things out loud, and we do know that sort of motivational interviewing, it reinforces that positive frame of mind for the patient. But if you ask a question that's a more negative slant, so something like, oh, so why do you think it hasn't worked in the past? Or why haven't you been able to maintain your exercise program? Well, I just get really tired of an evening, and I work really long hours, and I found it really hard to get up in the morning. And, when you ask a question like that, suddenly everything that I'm saying is really negative, and it reinforces back to the patient. So I think it's really good when you're listening to your registrars talk to your patients, like encouraging them to frame their questioning in a kind of positive light, like, why do you want to do this? Like, what's the big driver for you? Rather than, oh, why has this not worked for you in the past? I think, that trying to get the patient to talk about positive things, it reinforces it in their brain. Now, this is the Australian algorithm for the management of obesity, and it talks about the kind of classifications and assessment for complications, and then it sort of stratifies things down in terms of how you can, whether you would do lifestyle intervention, whether you might do a very low energy diet, or whether you might initiate pharmacotherapy or refer for bariatric surgery. And I quite like this nice, easy flowchart. I think it's quite good. There is an extra article that I think will be sent out as after this to you all, which has this flowchart, and it has some great tips on thinking about, in a practical sense, how you might assess and do this with patients. But I quite like this table. So follow-up is really important. And if someone's patient has decided they're going to be really committed, then you've got to do frequent review, and every 2 weeks initially, particularly if you're starting a very restrictive diet or a new medication or something like that that requires more close supervision. And consider early referral to other healthcare providers like a dietitian and or psychologist, because there might be a really good psychologist in your area that can help with some of the eating disorder behaviour that might be occurring for this patient that has never really been addressed in the past. And this kind of suggesting resources to promote patient self-management. So food diaries, exercise trackers, online programs, and we're going to talk a lot about these later. I've already mentioned the motivational interviewing aspect as well. Now, I'm just going to try and move this up. And ensure and think about how I'm going to follow this patient up long term and treat us for a chronic condition. Now, we do know that unfortunately you can't access chronic disease management plans and team care arrangements for straight obesity alone. So it's really important to think about. That's why that assessment of comorbidities is really important, because is there something else that actually will get them over the line, and now you can do the referrals for a dietitian or a psychologist under that training plan. Now, I do know that the RACGP Obesity Working Group are spending a bit of time advocating for getting for getting Medicare item numbers for management of obesity. So this kind of watch this space. Prevention, I think, is really important. So this is what's really important with all your patients, and there's certainly been this change now for us to actually focus on diet quality, and diet quality is actually more important than a patient's overall weight. So if you can improve the diet quality by increasing the variety of the foods that they're eating more vegetables and more fruit, you actually significantly improve their overall health and decrease the risk of disease. So that's why when I've got these patients, I say to them, look, I want to do your assessment, I want to do your height, weight, BMI, we'll do your waist circumference, but I actually don't care about your weight. I want you to be fitter, healthier, and stronger. And that's where I want our focus to be. And you eventually, weight will come off on the scales, but if you feel fitter, healthier, and stronger, then that's a huge win for us. And patients really like that, the focus taken off their weight and it being on this kind of positive outcomes. And it decreases their risk of disease. And certainly the effects on their internal health are actually seen long before any changes in weight. So this, I think, if I can send you home with any one point that focus on diet quality with your patients is important. I'm not going to talk about this much. This is Australian Guide to Healthy Eating. I hope you've all seen it. And the only point that I will make is for patients that are trying to lose weight, that plate is kind of for a person of a healthy weight. I generally try and replace most of the bread and grains and cereals with more vegetables, and that being more the focus for someone that's trying to lose weight or keep their weight off. But we'll talk more about diets. So in terms of life goals, this is for all your patients and for yourselves as well. So you're looking about 30 to 100 minutes per day, 5 days a week of exercise. So a half an hour, 5 days a week is actually quite achievable. And it's really important that patients don't increase their activity or intensity by any more than about 10% per week. So I'm sure you've all had these patients at the beginning of the year get on a health kick and they start walking a lot, and then they end up with plantar fasciitis, and then they get a lot of pain, and it just takes them like back so many steps. So it's really important that if they're starting out to just start really slow and build up each week. And that's just about moderate intensity exercise. And it's really important to encourage muscle strengthening activity as well. And the big thing is do what you love, and encourage exercise that people love. So there's lots of low-cost options out there, things like Heart Moves, Active Over 50s, some online workout subscriptions. So things like Les Mills have an online workout subscription, so you can just pay a fee per month and you can access all of the workouts at home and do them at home. But you can do things like renting a stationary bike, bulk buying gym classes, going in with personal training session with a couple of friends, and it significantly reduces the cost. And then there's the free options like parkrun, like I talked about. So there's 390 different parkruns across Australia. Newcastle has 12, I think, just here in Newcastle. My parents live in Tamworth. They helped set up the one in Tamworth when they decided with a group of people that they wanted to have one in Tamworth, and they helped set it up. Tamworth gets well over 200 people every parkrun every weekend, and that's on a bad day. The ones in Newcastle can get anywhere from 400 to 800 people, or they were pre-COVID, but you know, they're quite significant in terms of the draw card for people. But there's the Heart Foundation walking groups, there's YouTube videos, all sorts of things. The patient needs to find what's right for them, and accountability is key. So talk to your registrar, like what can you recommend in your local area? There's quite a few GP practices here in Newcastle that actually sponsor the park runs, and their doctors go each week. There's other practices that I know that run a walking group from their practice once or twice a week, and the nurse might go or a doctor might turn up and with a group of patients, and they go for a walk around their local area. So that, like, it's really important to think about what's available and what you might be able to do yourselves. Eat more vegetables. Basically, this is what I push. So these are basically the 4 things that I talk about with patients. So to reduce their portion size, so the size of their plate. So we do know that over history, over the last 50 years or more, our plate size has actually gotten bigger. And the research shows that we actually eat the same proportion of the food on the plate, regardless of the plate size. So if the patient can get a nice little tiny plate and just put food on that, that actually reduces the amount of calories that you eat. And vegetables and salad should be the focus. They should drink water and should reduce their alcohol. So that's the big things that I always push. And then you kind of go on for the other things like switching to reduce fat dairy. I say not to eat any carbs at dinner because that's just calories that are just sitting around and not being used up. Same with drinking lots of alcohol at night. And then no more than 2 bits of fruit per day. Schedule high quality treats because you can't live if you don't have your best quality ice cream once a week or your favorite chocolate every now and again, and avoid fads. So I'm going to talk about specific diets as well, but this is my just general advice that I recommend pretty much for everybody. So now we're getting on to level 2. So this is reduced energy diets. So this is where you're aiming for a reduction of about 2,000 to 4,000 kilojoules a day, and the patient has to keep a food diary. You can't keep track of it. So already we're moving into someone that needs to be more committed because keeping a food diary is actually really hard. And they need to be using some kind of resource to plan their meals. So WA has this great thing called the Live Lighter program, and they have these online meal plans, which are awesome, that are free. I really, really rate that. It's awesome. The CSIRO have got fantastic books. They've got a paid program that you can do online as well, Weight Watchers, all those sorts of things. So, but basically the way of reducing the calories is to target high-risk foods like alcohol, sweet drinks, coffee. So your milk coffees are a big contributor to that, cakes and lollies and takeaways. So it does require the patient to be a bit more committed, but still not hugely. This, in terms of food diary, this app, this Easy Diet Diary, is actually really good. And it's an Australian one, and it's a great one because you can hold your phone up and scan the barcodes of things, and it will find that product in their database, so that it makes it easier for you to add foods in. And it keeps track of your favorites as well. So that one is quite good. So I might launch our next poll, Glenn. I'm really interested to know if any of the doctors have actually ever kept a food diary. And I am interested if you can tell me if you know what equals 2,000 kilojoules. So 37% of you have kept a food diary, and I'm really interested in the chat what people think about keeping a food diary and if they found it easy or hard. And 63% of you haven't. If I can encourage you, if you've never kept a food diary, for you to download that app that I talked about and actually have a go at keeping one for a couple of days, just so that you can talk about it with your patients. It's actually takes a little bit of thought and sort of trying to work out how much, like, is this a cup, and actually you kind of have to measure things out a bit and work out like the volumes and the serving sizes, and doing that actually makes you think about how much food you're eating. So I really encourage you to have a go of it. So the 2,000 kilojoules. So the McDonald's Big Mac, yes, that's 2,000 kilojoules. The large bowl of Cocoa Pops and a cup of milk is definitely 2,000 kilojoules. I think the slice of banana bread just comes in, I think it's 1,800 kilojoules. The 2 cans of Coke is about 1,600, I think. And the 2 mid-strength beers, I think, I can't remember off the top of my head now. But it's still very high, still a lot of kilojoules. It's very easy for you to, have a large bowl of cereal, a cup of milk, full cream milk, have a piece of banana bread with your coffee. It actually is quite easy to suddenly jump to 2,000 kilojoules in a day. Or if you get lazy to kind of go, I'll just have a Big Mac on the way home, or a bunch of nuggets, which tends to be my go-to thing for going to Macca's if I'm really lazy. How much sugar is in that drink? I really like this, and normally I include this as part of the poll, but it was a little bit too tricky this time. Thinking about how many kilojoules or how much sugar is actually in different products, and so the Coke, the 375 ml can of Coke has 9 teaspoons of sugar in it, and you go, oh, if I had a glass of water in front of me and I was tipping 9 teaspoons of sugar into that, that's a can of Coke. But also, if you went to Boost and you got yourself a Mango Magic, medium size, which is not that big, it's got 12.5 teaspoons of sugar in it. And the Dare iced coffee, the 500 mils of Dare iced coffee, that's got 11.5 teaspoons. So it's really easy. Even the peach iced tea, like, that's got almost as much sugar in it as a can of Coca-Cola. And it's just so easy. Drinks are so easy to consume large amounts of kilojoules really quickly. And I really like this infographic showing portion sizes for patients and sort of giving them an idea about, particularly, a slice of meat should be the size of your palm, how a fist is, a cup, those sorts of things help with keeping food diaries. So now next step, we get onto low energy diets. So this is, I'm just mindful of time. So this is where you've got a target now of only eating about 4,000, 5,000 kilojoules in a day. So again, you're starting to get much more restrictive. So the pros to these, you often don't need to think about meals. These are the sorts of shake plans, things like light and easy, those kind of meal plan type things. It also includes intermittent fasting. For intermittent fasting, basically you aim for about 500 kilojoules on about 2 days of the week, and the rest of the time you eat what you want within reason. And that kind of comes under this thing as well. And all of these are quite successful for some people, but they can be quite expensive, except for the fasting one. And they do require more strict control of your energy intake. And I always say, what happens when you stop? You're probably going to put weight back on because it's often not sustainable. And potentially there's other ingredients. And I tell the story, a colleague here had a couple that were trying to conceive, and they were having lots of trouble, and they did a sperm count on the man, and he had a very low sperm count, and they're like, oh, this is really unusual. You're young and quite healthy, goes to the gym a lot. Are you using any shakes? Oh, yeah, he uses protein powder from the gym. He got them to bring the ingredients in, and we've got a toxicology service here in Newcastle that you can ring and give them the list of ingredients, and they'll actually be able to tell you if anything is a pseudonym for something else. Gave them the list of ingredients, and they came back and said, oh yeah, this here is a pseudonym for testosterone, and that's why he's getting such good benefit from the protein powder, and it's also reducing the sperm count. So that's the big thing with a lot of these kind of gym type products. You do worry about other ingredients that are in there that are not listed or are under a pseudonym. So that's all I'm going to say about those. And look, there's heaps of different shake plans and all sorts of things out there. But again, you're getting more adherent as we go along. And then we get to the very low calorie diets. So this is basically something like Opti-fast. They're designed to induce rapid weight loss. You're looking at a maximum of about 3,000 kilojoules a day. They can be quite expensive, anywhere between $300 to $500 per month. So that's all your food. And they're often sold as high protein, low carb meal replacements. And basically you're inducing ketosis through energy restriction and trying to get the body to burn fat. So they're not suitable. It's not tolerated by everybody. And basically the way to use them is you start with about 3 to 4 shakes or bars each day with additional vegetables, sometimes a small meal to kind of make it a bit more tolerable. And then later on, as you go, you can add a small amount of fruit and dairy. And these patients need like a weekly review until they're stable, and you really need to have a dietitian doing supervising as well. They're usually only used for about 8 to 12 weeks. And look, often it's because you're trying to get someone for bariatric surgery or for surgery for whatever reason. And so that often used short term. You can use them up to 12 months if it's tolerated, but you do need to think about like micronutrient deficiencies and all sorts of things like that can start occurring with this kind of thing in a long-term basis. So, and you should be using it. They should have close medical, which can be you, but they really need a dietitian overseeing this as well. So certainly can be really, really successful for patients. But again, we're requiring someone to be really committed now in terms of diet. So that's what I'm going to talk about particularly for diet. There was some questions particularly about ketogenic diets, and which basically is having a very low carbohydrate intake, which is encouraging the body to burn fat rather than glucose. Some of these diets tend to have a higher fat, much higher protein then I think is probably healthy. Again, the whole point of these is that you increase this their satiety so they don't get as hungry, but it often takes a couple of weeks to work, and you do get other kind of long-term side effects, things like the bad breath. They can get constipated because traditionally ketogenic diets have very low fruit and vegetable intake with them. And you can get nutrient deficiencies, particularly calcium, vitamin C, and most ketogenic diets, patients will regain the weight once they stop. So the best diet for the patient is the one that they can stick to. I can't stress that enough. So there's tons of diets out there, but the best one for the patient is the one that they can stick to long term. Consider medications if someone's got a BMI of 30 or a BMI of 27 to 30 and they've got obesity-related complications. So their arthritis is really bad, they've got diabetes, so whatever is going on for them. But also consider in above 25 if they've got an Aboriginal Torres Strait Islander or Asian population. So you can actually be thinking about this in a lower BMI. Now, let's go through them. So Orlistat or Xenical. So that basically reduces your absorption of fat. So you're looking, traditionally you get a weight loss of about 3 to 3.5% over 12 months. You can get improvement in HbA1c, and you can reduce the incidence of type 2 diabetes by 37% in someone that's above a healthy weight. So that's actually quite good, and it's very cheap. So it's the only one that's on an authority script, so $6 a month. And so that's why I mention it. It's not used very often anymore, but I mention it because it is so cheap, and it requires a patient to be adherent. And so once they start taking this, they really need to be adherent to a low-fat diet. There are side effects, things like steatorrhea, fat-soluble vitamin deficiencies, and you can get calcium stones as well. But you might actually have a patient where this is quite, that can't afford any of the more expensive ones we're going to talk about, and that, this actually works quite well for them. So talking, diet and lifestyle, they need to maintain a low fat and high fiber diet to avoid side effects. And about 30% of fat that they eat is then excreted, and it just maintains that adherence to that low fat diet. And you need to review them every 1 to 3 months to check, if any side effects in their weight, blood pressure, and heart rate. So, and promoting that exercise as well. Now, Duromine is the one you're probably most familiar with. So it's an appetite suppressant, and it's available in various sizes. You can get anywhere about 3 to 5 kilos of weight loss over 6 months, but it is very expensive. So we're looking at $80 to $100 per month. In terms of prescribing it, the criteria is that they've got a low intermediate cardiovascular risk and no evidence of cardiovascular disease. So that's really important. No serious psychiatric history or substance abuse. No clinically significant increase in their pulse or blood pressure when they start taking Duromine. So that's why follow-up's really, really important. And they have to be compliant with follow-up. I rarely see this used, taken by patients well. They tend to stop, start, and they don't do all the lifestyle measures. So I think it's really important to do that proper counselling, particularly if someone's coming back for a represcription, to actually go, okay, what's actually going on here? What are your goals? How are you using this? Look, the side effects, dry mouth, insomnia, agitation, constipation, tachycardia, but the contraindications are the big ones. So hypothyroidism that is not controlled, that's contraindications. Any history of drug, alcohol, or severe psychiatric illness, or particularly anxiety, you would never use it because it tends to increase, your heart rate and those sorts of things when you start taking Duromine. So you don't want to throw someone into a mental crisis. Obviously, no pregnancy, and use of MAOs, so they can't be taking MAOs. And if they've got history of seizures, cardiac arrhythmias, or significant hypertension, then you would be very, very careful using it. In terms of using it, you should be counselling, setting specific goals, start with a low dose, review them after a couple of weeks, and basically you're aiming for the dose that gives them the maximum benefit with the least amount of side effects. And if you're not getting any weight loss after a couple of months, then you should stop it. Most registrars that I've come across are reluctant to keep prescribing this, but there is some good evidence to suggest that long-term use can be appropriate up to 2 years. But it really comes down to patients' adherence and their ability to afford it. One of the big things that the obesity working group or special interest group talk about is that, if we have a patient with hypertension and we put them on medication, once they get to a normal blood pressure, we don't just take them off their medication. That means the medication's working. And I think it's important to think about these weight loss medications a little bit like that. So if something's really working and we're getting weight loss and things are going good, why are we stopping this? This is the medication that is treating their chronic disease. So I think it's really important to be thinking about how it's used. And certainly some of the obesity specialists will add Duromine into other things because it has a specific appetite suppressant effect. They might add it on to another medication, something like Saxenda. So this is a glucagon-like peptide agonist. It's the only one that's listed for management of weight loss. And Victoza is the one that's very similar, that's used specifically for type 2 diabetes, is very expensive. So you're looking at about $380 a month. And side effects tends to be what gets most people. Now, in terms of using it, because it's a subcut injection, the patient needs a lot of counselling and a lot of education in terms of using it, and how they manage the side effects. So starting really low dose on a daily injection and building up slowly can help with those side effects. So you start with that 0.6 milligrams daily, and then you work up very, very slowly to a maximum of 3 milligrams. It's again, use the lowest dose that's effective and limits those side effects. And you basically will get a good amount of weight loss up to 12 months. But with most medications, once you stop them, the patient will often regain the weight when you cease them. But it is really effective. And like I said, some of the obesity specialists will actually combine Saxenda with Duromine, but obviously that starts getting very expensive. Because you get the weight loss effect from the Saxenda, but then you get that appetite suppressant effect as well. So you can certainly combine medications, but you have to do it under very close supervision and monitoring side effects. Now, Contrave is the new kid on the block. So this is looking with the hypothalamus, and it's trying to kind of that dopamine reward system to reduce hunger and craving. So again, very expensive. It's about $240 a month, and you get quite significant side effects. Nausea, headache, vomiting, diarrhea. It can also lower your blood glucose level as well. So you need to be very careful if you've got a patient on any medications that are that potentially will already reduce their blood glucose level, or if they've got diabetes. And contraindications like uncontrolled hypertension, if they've got bipolar, because a manic episode is listed as a potential side effect. And if they're on chronic opioid treatment, obviously you can't use this because you'll put them into withdrawal straight away. So that's the main contraindications. So obviously the risks for diabetics on insulin are sulfonylureas, but it doesn't mean you can't use it, but you just need to monitor them closely. If this is a quite good one, if you've got someone that's got any kind of kidney disorders, then you can use a lower dose. And there's a picture. The beauty of this is that it's tablet form and not a subcut injection. So that is what most patients, they don't want to be injecting themselves. So and it's a little bit like, with the smoking cessation, you start with, 1 pill, and then you increase to 2, and then to 3, and then to 4. And then you just kind of see how long you can keep the patient on the dose. Now, again, if they're not losing weight, then you should stop it. And all of these medications need a lot of counselling about their goals. How are they going to manage their diet? What are they going to do about exercise? When are they going to follow up? All of those sorts of things. So it's really, really important to set those expectations early with patients. I mentioned Topiramate. I have heard some of the obesity specialists do use this. It's very, very cheap. So you're looking at $15 for 60 tablets. It's used off-label. It's an anticonvulsant for seizure and migraine prophylaxis, but it can be quite effective. But the side effects are the things that get patients. So it has quite a lot of side effects, and most patients can't tolerate the side effects. But if you've got someone that has a history of migraines and happens to be above a healthy weight, then it might be something that could work quite well for that patient. But again, you just need to manage the dose. And you can start really low. And there have been reports of that, again, combining with Duromine, and that's very, very effective, but most people can't tolerate the side effects of the combination of the two. So I just mention it because it's really cheap, but it's not one that's studied extensively. And this is a great table, which you'll be able to look at later, that compares all of the different medications, the side effects and the contraindications. So you guys can look at that later. So very briefly, I'd just like having this table to sort of give you an idea about the diabetic drugs and weight changes. So obviously thinking about the medications that your patients are on and whether you can get them from these kind of weight gaining type diabetic drugs onto more kind of weight losing ones, but that's going to be specific to your patient. So I'm sorry for going over time. I mentioned this very briefly because of the court case that was quite a few years ago of a GP that was sued by a patient who was quite overweight and ended up developing, I think, liver cancer. and they sued their GP because they were never referred for bariatric surgery. That case was very significant because initially the patient won that case, and it was overturned on appeal, but it did make many of us very uneasy at the time. And so I think it's really important to talk about the ethical stuff with your registrars and your duty of care, in terms of, discussing weight loss with your patient. And if they don't follow through with your advice, and how they document that and talk to their MDO. So I think it's really important to encourage your registrar that they should, be very clear with their counselling, and document that in the notes. Basically, that article that I mentioned before talks about management of obesity, but basically thinking about that for patients over BMI of 40 or over 35 with obesity-related complications. And certainly, locally here in Newcastle, we don't have any public lists for bariatric surgery, and so patient has to be financially able to afford the surgery. Other parts of New South Wales, there are public obesity clinics where patients can be worked up and referred for bariatric surgery. So it really depends on what happens in your local area, and that's just the different options that are available. And in terms of post-op follow-up, there are a couple of specific things in terms of avoiding non-steroidal anti-inflammatory medications, and the need to encourage your registrar to adjust the things like their medications, the blood pressure medications, statins, the diabetic medications, and they might need quite significant nutritional supplementation as well. So hopefully they'll have dietetics follow-up, but your registrar might need to talk to their dietitian. And that slide is just looking at the more severe the bariatric surgery, the more weight you lose, but also the more nutritional concerns that you end up with and the more complications you're likely to have long term. So just to sum up, key teaching points to talk about with your registrars are to listen first and don't just tell the patient what to do, to listen to what they've tried before and to think about what they want to achieve going forward. Patients need to be positively engaged and follow up in the long term. And it's really important to tailor and combine your interventions depending on their previous attempts at weight loss, their current health status, and their likely adherence and motivation. And the patient needs to acknowledge that as well. And then you can pick, at what point you go in with a reduced calorie diet and, Duromine, or you might use a very low calorie diet and no medication, or, it's important for you to think about what you do with the patient and talk about with your registrar. And encouraging your registrar to have a plan for following up and supporting the patient post-initiation of any medications or even represcribing them. And your long-term goal is maintenance of about 5% weight loss. And I think the big thing too is that assessment. We don't do the assessment enough as well. So thank you very much for your time, and I really appreciate you listening. There was one quick question online, Simon, that I just answer, was about fatty liver. And in terms of treatment for patients that have fatty liver disease, if you can get someone to lose 5% of their body weight, if they've got fatty liver disease, then that will improve their liver function. And really the only management that we have of that is weight loss. But we do know that there is this, that they're probably going to find it harder to lose weight for some reason, but they're not quite sure why. But certainly if you can get some weight loss, you'll improve all of their other cardiac markers and diabetes control and things like that. Okay.
Al, thank you very much.
I'm sorry.
Oh, no, there was
time.
actually a comment coming through. Please don't rush. This is fantastic. And there's lots of lovely comments about how much it was enjoyed. And I put in a couple of references, but also very much as Alison mentioned, I think for the first time possibly, and maybe hopefully something we'll aspire to doing in the future, we developed a teaching plan on this topic to launch for this webinar. So you can go there and visit that immediately after the webinar and use it as early as tomorrow with your registrars in practice if you so wish.
I think the slides will be available to people afterwards. Excellent. So I just thought I'd mention, I've put some self-management tools and a few things for you to have a look through at the end. Just some other services and things that might be helpful for your patients. And and apps as well. I always give a plug for Zombies Run. That's my favorite app ever for exercise. And that food switch is a really good one too, because you can scan the barcode of a food product and then it will give you other healthier options, which I quite liked. So that's a good one too. But I've put tons of resources and links as well for you to have a look at for everything that I've included.
Thank you. Yeah, so I think it's really important that we acknowledge the ongoing support of the AGPT and the Australian Government for funding GPSA and GPSA's education program. We've got a packed education program coming up. Next week, next Wednesday, Glenn will be talking about the NCCER and employment contracts. So a must for all you supervisor practice owners and employers. On the 10th of June, we'll be talking about the recent project, which is the Registrar Beach type study, which I think will be of interest to every supervisor, how you can use the information that's come from that now over 10-year-long educational program around registrars' practice to help the clinical exposure of your registrars. And then a fun and very, very pertinent topic on clinical reasoning, the clinical reasoning game at the end of June. So make yourself available for those webinars coming up. So thank you so much, and all the very best for supporting your registrar in the practice on this incredibly important aspect of care. So thanks very much, Alison.
Thank you very much, Simon. I just want to say to all the supervisors, thank you so much for everything that you do, because like Simon, I work with registrars on the other side as part of their training, and we couldn't do our job without you guys. So I really appreciate everything that you do, and thank you for listening. I hope you found it helpful.